Okay, it's top of the hour. Thank you everyone for joining us today for our webinar. Just a couple quick things before we get started. You can submit any questions via the chat function throughout the webinar, and we'll try to get to those at the end of the webinar. And your certificates for the US attendees will be available Friday afternoon tomorrow by logging into your account. Irene, if you're ready to introduce our speaker, go right ahead.
Thank you. Thanks, Kim. So welcome to everyone attending today's webinar. My name is Irene Zoppi. I am the Senior Manager for Clinical Education for Medela in the U.S. Last summer, during the height of the pandemic, Medela conducted a series of webinars with renowned human milk and lactation researchers on understanding the impact the coronavirus had on breastfeeding for families. In February, Medela continued this effort with a presentation series titled Breast Milk Initiation in Crisis, the After Effects of COVID-19. Today is the third presentation in this series of 5 webinars. Today's webinar, Changing the Prenatal and Intrapartum Care Paradigm to Improve Lactation Initiation During the COVID-19 Pandemic and Beyond, is presented by Dr. Diane Spatz, Professor of Perinatal Nursing at the University of Pennsylvania School of Nursing and a nurse scientist in lactation at Children's Hospital of Philadelphia. Dr. Spatz, we are delighted to have you speak to us today. And go right ahead.
Great. Thank you so much, Irene and Kim, and thank you to everyone who has joined in the United States and globally. I always find it a little bit tricky when I'm thinking about these presentations, knowing that we may have mixed audiences, some whom of which may have heard some of my past presentations and some of you who may have not. So it's always a little bit of a tricky balance to kind of decide what information to include and not include. But the things that I promised that I would include in this talk today are some case studies, which I have, some tools, which I have, and research, which I have. So we're covering those 3 items as promised. So these are the objectives that you got when you registered for this program, and we do have to thank Medela for sponsoring me or sponsoring this program. They did not have any input into the content of this presentation. So I do share a joint appointment between the University of Pennsylvania School of Nursing and Children's Hospital of Philadelphia. And I start with this slide on every lecture that I do because I really want participants to understand my multiple roles. We do have a whole semester course on human milk and lactation at Penn Nursing. The course has celebrated its 25th anniversary. I was recruited to Children's Hospital of Philadelphia in 2001. At that point, CHOP had only one IBCLC. That was all that they had. And one of the reasons I said yes to CHOP when they recruited me is because of our Center for Fetal Diagnosis and Treatment. And in 2008, we also opened our special delivery unit. So the only babies that are birthed at CHOP are infants that have complex surgical anomalies. So their parents know even before they're going to be born that their child is going to be critically ill. So baby Charlotte has a giant encapsulation. Her mothers knew that they would have a child that would be critically ill. Lindsay, the birth mother, was the pumping mother, knew she would have to pump for a long time. This is her at her point where she was able to transition to direct breastfeed, and this is her first birthday. She received 100% human milk for her whole first year of life, and her mother also had much excess milk because she produced over 1 liter of milk a day for the whole first year, that she also became a donor to a milk bank. So I like to start with that story because I'd like you all to understand that human milk and breastfeeding is transforming. It can transform a family's life. It can transform a child's life. And we need to enhance the value of human milk and breastfeeding in the US and abroad, which unfortunately has been put at great risk during this COVID pandemic. So in terms of transformation and understanding how important human milk and breastfeeding are, I share with you this picture of Lindsay and Charlotte today. So Charlotte is in perfect health. She has no residual side effects from being a critically ill baby who received lots of pain medication and went through withdrawal while she was in her NICU. She is super smart, healthy, has no concerns at all. And Lindsay, based on her experience being a family in the CHOP NICU and her past experience working for national nonprofits, when a job opportunity came about for the Human Milk Banking Association of North America, I told her that was the job for her. And she serves as the executive director of Himbana. And I started our milk bank at CHOP in 2015. So we continue to have this ongoing relationship. So I wanted to start with some important questions for you, because as we're going through this presentation today, I'd really like it to be a call to action for yourself. I'd like you to decide to change something in your practice where you are currently working. So I want you to think about how the pandemic has impacted birth and breastfeeding in your facility. I'd like you to think about your breastfeeding initiation rates, and are they high enough? And have you seen any change in initiation because of the pandemic? What about the use of formula in your institution? And have you seen an increased use in formula supplementation since the pandemic? What % of your families have interventional delivery? How many of them have labors that are induced? How many of your families currently have cesareans in your institution? And if you think about for both healthy and for sick babies, what are your human milk rates at discharge? So I have many appointments that I hold that have informed this presentation, and I've been working actively both in the US and across the world to really try to improve human milk and breastfeeding. And just this morning, I had my first meeting with a new UNICEF task force on small and sick babies. So I mentioned this in previous presentations, but I feel that it's essential to again mention, because we know through multiple publications that birth and breastfeeding have negatively been impacted in terms of separation of mother and infant dyads, parents getting conflicting information from healthcare providers, missing time with friends and loved ones, and also the negative impact of not having appropriate in-person, tangible, technical breastfeeding support, both during the birth hospital stay and beyond. And then maybe some of you have joined the webinar earlier this year that I did with Dr. Bodie, but we do have our call to action, which really details out steps that you could take in your institution to ensure the provision of human milk and breastfeeding. So I'm going to start out with my first question, and this goes back to the antepartum period. Do all parents receive adequate prenatal education about breastfeeding? Is that a myth or a fact? And it's interesting because I was recently lecturing to a group of pediatric dentists, and the pediatric dentists held very strong assumptions that all families were getting information about human milk and breastfeeding from their OB healthcare provider. But we know that that is not really true, because if we had all families really getting excellent evidence-based information during the antepartum period, our breastfeeding rates would not be suboptimal. Now, some would argue that we've done a great job because we're hitting most of the healthy people 2020 targets. However, I would argue that those targets are not high enough, and where we really need to make an impact is on exclusivity and continuation. And those rates continue to be quite low. We still have 3 out of 4 infants in the United States that don't get 100% human milk diet for their first 6 months, which means they are at high risk for suboptimal health and developmental outcomes. We also have tremendous geographic disparities based on the state or the area in which families live. We have families across race and ethnicity. We have disparities across income groups, and we have disparities related to enrollment in the WIC program. We have to acknowledge that structural racism and inequality have played a tremendous impact in the disparities of breastfeeding initiation. We know that not only are African American families less likely to initiate breastfeeding, but in hospitals that serve those families, these same hospitals also do not have pasteurized donor human milk available, and they may not have any access for the families for technical breastfeeding assistance and support. And this is truly concerning because of the lack of human milk and breastfeeding in our Black and Latina populations. We see that their children have higher rates of health concerns. So higher rates of acute otitis media, higher rates of necrotizing enterocolitis, higher rates of gastrointestinal infection, and in the Black population, 2.2 times the number of excess child deaths and 1.5 times the number of excess child deaths in the Latina population. And when we think specifically in the African American population, I've done work on this with colleagues of mine across the United States. And we know that there are historical antecedents and historical trauma that has impacted African American families being able to make decisions to provide milk for their baby. And subject matter experts agree that there are tremendous health equity concerns when trying to improve breastfeeding in this population. In fact, to that end, we have a new research study that we have launched at Penn, and you can contact me if you are interested in more information about that, where we are doing a mixed method study with African American families who do breastfeed for 12 months or beyond, because we believe that we can learn from their voices and their stories ways in which we can help other African American families make informed feeding choices and also be able to meet their personal breastfeeding goals. We really need to have the current prenatal care paradigm change. And this is my editorial that addresses this concept, because we know in prenatal care that breastfeeding is not sufficiently addressed. And we also know that there is a lot of time during prenatal care and birth focused on preparation for labor and birth, but not for what comes after, being a new parent and being a breastfeeding family. So all families should have this information. We shouldn't make judgments about families based on their skin color, their income, their job description. We should be giving information to all families about the science of human milk. And at every single prenatal care contact, we should be having a conversation about human milk and breastfeeding as part of that prenatal visit. So the first step of my 10-step model is on informed decision-making. And even though this model was developed for vulnerable infants, since the pandemic hit, we have found that this is really important for all of our families, whether or not they have a quote, vulnerable infant or not, because of what has occurred with the pandemic. So I recently developed a new tool, and this is an infographic on the 10-step model. And so this walks you through each of the steps in a beautiful infographic fashion, which is often much more easy for both practitioners as well as for families to be able to engage and digest the information. So that is my first new tool that I wanted to share with you. So we know informed decision is not happening equally, because if it was, we would not have the tremendous disparities that we do in the US and as well around the world. So how do you teach families about breastfeeding? So if you think about what the standard of care is, at the first prenatal visit, there is a box to check. And that box to check on the prenatal form puts someone in a box and it makes them choose breast or formula. And maybe someone also says to the family, you know, you should really consider breastfeeding because breastfeeding is good and you should do it. But most families, if they want information about breastfeeding, have to go out and seek it on their own. They have to sign up for a separate class. Sometimes they have to pay for that class. So not all families are getting equal information. So what should be occurring when we do prenatal care? First, we want to ask the family, and this is not just the person who's giving birth, but the whole family. Tell me what you've heard about human milk and breastfeeding. What are your concerns? Let me share with you the science of human milk. And how can I help you make human milk and breastfeeding work for your family and for your lifestyle? We need to focus on sharing the science. We need to focus on teaching families that human milk impacts every single organ in the child. It impacts the brains, the eyes, the lungs, the GI system. Every single organ is impacted by the exposure to human milk. We need to teach families that human milk and breastfeeding are dose dependent, and that while any human milk is good, the longer and more exclusive human milk results in even better outcomes. So for example, with protection against ROP and BPD, we know that for the sick baby in the NICU, the exposure to human milk in the NICU alone protects those children. But if we want to, for example, protect against otitis media, we know that exclusive breastfeeding for the first 4 to 6 months is critical. So we want to be able to actually go and share scientific research with families for them to understand how critical human milk and breastfeeding is for the health of their child and the health of their family. Furthermore, having families understand what human milk is versus what formula is. Many families have unrealistic ideas about what formula is. They think it is something magical or special. They do not know that it's made from cow's milk or soybeans. Parents are not taught about the milk itself and how the milk works. So, especially during this time of COVID, helping parents understand that human milk destroys pathogens, that human milk contains antibodies which are transferred to the infant, that human milk contains substances such as lactoferrin and white blood cells to protect the baby from infectious processes, human milk oligosaccharides which are probiotic and prebiotic, antioxidants which protect the baby's eyes and the baby's brain and the baby's lungs, and the stem cells, which we know transfer into the baby's brain. And we know that babies who receive human milk have more white matter and gray matter, and they have bigger brains. So we have our Power of Pumping DVD. Again, is another tool that is available that you can utilize to teach parents the science of human milk and the science of breastfeeding. So I want to give you now some case exemplars about informed decision making. So we had a family who participated in group prenatal care. And if you're not familiar with group prenatal care, that is the centering model, which is a midwifery model of care where you bring families together as a group to go through their pregnancy journey. And you focus on health assessment, education, and empowerment. So in group prenatal care, we had a heterosexual couple who was a father who had 2 other children who were both formula fed, and a mother who had 2 other children who were both formula fed. And during the current pregnancy that this mother and father were having together, they had a baby who had multiple congenital anomalies. So there were multiple organs in his body that were affected. And the couple said to me at the start of group prenatal care, they said, you know, I fed, my children were formula fed. The father said, the woman said, my children were formula fed. They are all just fine. There is nothing that you can tell us that is going to change our mind. We are going to feed our baby formula. And I said, okay, that's fair enough. But I said, today's session of group prenatal care is about human milk and breastfeeding. So I hope that you will at least stay and hear the discussion with the rest of the families. And so during group prenatal care, we focus on the science and how families can get the best start. And one of the fathers, a different partner, requested information. His first question was, well, can you tell me what makes human milk so special? And so again, I went through this science and I began to talk to the families about the various components of human milk, how they weren't present in infant formula, and how each of those components were going to make an impact on their child and their child's health specific to their child's diagnosis. And this family who said, there is nothing that you can tell me that will make me change my mind or our minds, after the class came up to me and they were actually quite upset. And they said to me, Dr. Spatz, we don't understand. We have 4 children between the 2 of us, and we have never heard any of this information before? Why did our healthcare providers didn't give us this information? Why is this all new information to us? And I said, I'm really sorry. I can't speak to where you gave birth before or your healthcare providers before. I don't have the answers of why you didn't have this information, but I can tell you what we do at CHOP. And what we do at CHOP is research and science. And that's one of the reasons you are here to have your baby with us, because we take care of babies with congenital anomalies. I said, you know, it's your decision, whatever you think is best. And they both adamantly stated, we want human milk for our baby. We would have given human milk to our other children if we had known. And in fact, this mother initiated milk expression, developed a complete and full milk supply, and continued to provide milk not only during the hospital stay, but beyond. The second case exemplar comes from a personalized prenatal intervention that I did. This was a heterosexual couple who were quite young. I think they were 19 and 18 respectively. The father told me that breastfeeding was gross and nasty and wanted nothing to do with it. And he had very negative body language. And the mother was very, very concerned about putting her baby to the breast. That was the concern that she voiced. And so I first started out by asking the father what he knew about formula. And he said to me, well, formula is amazing. It has vitamins and it has minerals and it's scientific. And I said, okay, I said, tell me what you know about cow's milk. And I said, because human milk is made from either cow's milk or soybean juice. And the father jumped up from the table and was like, what do you mean formula is made from cow's milk? That's nasty. Do you know what they do when they make cow's milk? It's dirty. And he was very anti-cow's milk. And he looked at his partner and he said, you're going to pump for my baby. And she did indeed did indeed initiate pumping for her child. But we also emphasized to the father that you have to have skin in the game too. And we have this job list for you to do. So this is another tool that you can utilize in your practice. This tool was published in our Pump Early, Pump Often QI project that was published in 2015. My last case exemplar about informed decision-making involves two mothers. Now, when you have two mothers, the pregnant mother or the pregnant person is going to be the predominant breastfeeding parent because they are the person who gave birth. But the other mother could induce lactation and or participate in non-nutritive suckling at the breast. And skin to skin is certainly important for both mothers. Now, we did current research. This is with my PhD student, Nina Gentriel, and we looked at same-sex mothers and their experiences. And we found that very few same-sex mothers were getting any type of evidence-based information from their healthcare providers, and they were not being given information about inducing lactation. And interestingly, one family who we interviewed specifically said, had they not had their child transferred to Children's Hospital of Philadelphia because of his diagnosis when they were still pregnant, they would have never known or heard of induced lactation. So again, the importance of personalizing interventions for all families so that they can understand how human milk and breastfeeding may work for their family. So I'm just going to share yet another tool, which is the Skin to Skin DVD. And this is just a short, less than 2-minute trailer about the importance of skin to skin. and your infant will also experience time that that child is yours. That's such a medical.
Obviously, the bonding. It's just been phenomenal. Watching her reaction when she's on me.
So this is yet another tool that can be utilized to help parents understand the importance of skin to skin in their lactation journey. We also have to prepare people not only about the science of human milk and the physiology of lactation, but we also have to prepare them to know that it's going to take time and effort and commitment. And especially again during this COVID pandemic, where people are only in the birth hospital sometimes for 24 hours, it is likely that they may be discharged without ever a lactation professional setting eyes on them and their child. And so the family really has to have a lot of prenatal anticipatory guidance to understand how to work through challenges if they have them. Again, thinking about that prenatal care paradigm, conducting an antenatal risk assessment prior to birth and sharing that risk assessment with the family so that they understand what they can do to mobilize their milk supply. So this is another tool that I've developed that has been published in the Infant Journal, and it goes through why it's critical to do an antenatal risk assessment. Being aware of factors such as first-time mothers, BMI over 30, age over 30, the impact of diabetes on delay in lactogenesis 2, and the possible impact of both PCOS and infertility. And so if there are risk factors, we want to proactively manage milk supply. We also want to be aware of those families who may not be able to have a complete milk supply. And this is a new article that has just been published earlier this year that focuses on how we help these parents prepare. Because if someone has had alteration of their anatomy, their milk making capacity may be altered. So if they've had augmentation, it may be altered depending on the type of procedure. If they've had reduction, their milk supply is likely to be very compromised. If they've had breast cancer, chemotherapy, or radiation, we also know impact milk supply. So we want to help these families understand that their goal will be to maximize their personal milk-making capacity. We also want to assess people prior to birth and look for the presence of widely spaced breasts. And we want to look for those parents who report no changes in their breast at all during pregnancy. Because with insufficient glandular tissue or glandular hypoplasia, these parents should not be prepared to think that they are going to come to full volume. And parents such as these are some of the reasons we have groups in the US like Fed is Best, who really talk somewhat negatively about breastfeeding because they think that if people breastfeed, their child's going to have harm, hypernatremia, dehydration, hyperbilirubinemia. When in fact, if we actually assessed people appropriately and gave them this information prior to birth, not to scare them, but to understand that they may have a compromised milk-making capacity. During that antenatal period, we also have to engage and empower the family. We want the family to understand that only the lactating parent can make milk specifically tailored for the child, but we need to engage the other family members. So one of the things we started early on at Children's Hospital of Philadelphia is having families quarantine together prior to birth so that there would be a support network who is quarantined and safe to help support the family. We had them set up a breastfeeding support network prior to birth and set up contingency plans in case something didn't go as expected. We need to create a sense of urgency about milk supply, because if we don't have milk in the short term, we're not going to have milk and breastfeeding in the long term. So does this approach and do these interventions work? Well, earlier in 2020, we have a study that was published about our group prenatal care lactation outcomes. And remember, not all of these families come to Children's Hospital of Philadelphia with prenatal intent. However, 100% of the families who participated in group prenatal care did initiate pumping or breastfeeding if they happen to have a healthier child for their infant, and an impressive 87% are discharged from either the neonatal intensive care unit or the cardiac intensive care unit on human milk and breastfeeding. So these rates are higher than national statistics for healthy babies. These are higher than the CDC data. So again, helping families see how critical this is in their and their family's journey. We also have a current study at CHOP about the tailored prenatal intervention that I developed, and I do. And this intervention provided by a PhD nurse includes prenatal risk assessment, including family history and exposure to human milk and breastfeeding, teaching the science of human milk and the physiology of lactation, demonstration of all the equipment that they're going to need, the power of pumping DVD, the skin-to-skin DVD, and the involvement of family members. Now, this next slide is confidential, so I ask you to not share it, and it is not in your handout because the article is just submitted for publication. But what we did was we looked at the CFTD mothers, and we looked at their initiation rates, their continuation rates, and as you can see, if you look at our initiation and continuation rates at all time points, they are statistically significantly higher than the current CDC data. Furthermore, we had over 1/3 of this population who actually breastfed their children beyond a year. So how we address the current antepartum prenatal paradigm is critical. We want to ensure when families make an informed feeding choice that they can actually be able to effectively establish supply. So some people around the world would recommend antenatal expression of colostrum. However, you can't convert from lactogenesis 1 or secretory differentiation to lactogenesis 2 or secretory activation without the birth of the baby and delivery of the placenta. So I think the jury is still out about whether or not this is truly indicated, and more research is warranted. Now, remember I asked you about the birth hospital practices in your hospitals. So this is an integrative review that looked at the impact of oxytocin on breastfeeding outcomes. And they looked at 26 studies and 34 measures of breastfeeding. And you can see 50% said less optimal, 26 had mixed, and 24 said there was no influence. But if we think about this from a per person incident, you can think that in 3 out of 4 cases, that person who was exposed to oxytocin may have some challenges with breastfeeding initiation. So think about your induction rate in your hospital. How high is it, and how many of your dyads are at risk for having suboptimal breastfeeding initiation because of the impact of labor and birth? What about cesareans? Cesareans have been implicated as a reason for mothers not to be able to effectively establish lactation or have a delay in lactogenesis too. So this is a study just published earlier this year about 468 dyads at Children's Hospital of Philadelphia. And all of these persons delivered via cesarean. We looked at time of newborn and placental delivery, which occurred within 2 minutes of one another, which is probably important for the initiation of milk supply. And then we looked at time to first expression. 90% of our mothers initiated pumping or breastfeeding if their child happened to be healthy, which is not the majority of our children because our children are all critically ill. And that occurred within the first 6 hours. And all of our families are using the Symphony pump with initiation technology. We only had a small portion of people who initiated after 6 hours. So that first hour and that first 6 hours makes a difference. Now, what's really interesting is even if people had lactation risk factors, and we looked at first pregnancy, we looked at age, gestational diabetes, and exposure to steroids, since a lot of our families get steroids, and that is a known potential risk. And we found that even if people had risk factors, they did not impact it. What really impacted everything was that frequency of pumping / feeds in the first 3 days. So we have to have a sense of urgency. Our families need to understand that the first hour matters, the first 6 hours matter, and the first 3 to 5 days matter. So it's not the cesarean birth that is the problem. It's how we manage them post-birth. So if a baby is healthy enough to breastfeed, we want to have that baby breastfeed. So this infant underwent fetal surgery for myelomeningocele, but was still able to go to the breast in the operating room. And you can see Dad is there helping too. Now, skin to skin is also critical for effective early breastfeeding. And unfortunately, skin to skin rates remain low. Even for vaginal birth. And this is a brand new published systematic review looking at skin to skin after vaginal birth. And rates are really quite concerning. Furthermore, the pandemic has really negatively impacted skin to skin. And this comes from data that the CDC collected last year. And you can see that we had hospitals who discouraged or prohibited it. So 20.5% of hospitals, that is 1 in 5 hospitals. This is unacceptable. 1 in 5 hospitals who were discouraging or prohibiting skin to skin. Now, why is this so critical? This is a great newly published article that looked at predisposing factors for excessive weight loss in term and late preterm infants. And you can see down here in their findings that the lack of skin to skin, a lower postpartum depression score, a higher postpartum depression score, a lower latch score were all predisposing factors to exclusive breastfeeding and weight loss. Okay, so this lack of skin to skin is of great concern. So then we need to think about the weight loss. And remember, I did ask you again, how many of your families have induction of labor? How many of your families have epidurals? How many of your families have interventional birth or cesarean birth? And we know the more information we do during labor and birth, the more fluid we are exposed to. And in this newer study published by Dr. Di Tommaso, she found that more than presumably, and these were all presumably healthy dyads, more than half of the kids lost more than 7%. And when that occurred, the use of formula increased markedly. So that tells us, again, that we need a proactive approach. We need to start moms pumping right away. We need to supplement with express milk versus formula. And our number one goal should be protection of milk supply. So what we really want to think about during that short birth hospital stay is the infant actually latching on and suckling effectively? Because if the baby's not suckling effectively, then we're going to compromise milk supply. Does the lactating parent have risk factors that we're concerned are going to delay lactogenesis too? Then we need to prioritize milk supply. So we know there's a critical window to effectively establish lactation. So if we have parent-infant separation, if the infant is not feeding well, or if we have risk factors, we want to prioritize milk supply. We want to have skin to skin, not just at birth, but around that whole hospital stay. We want to start them pumping, and we want to focus primarily on stool output, not urine, because urine would be a late indicator. And if we had to supplement, it would be much better to do so with pasteurized donor human milk so that we don't change the microbiota of the infant. But even if we're going to use PDHM, we would then protect exclusivity, but we still have to get the mother pumping because otherwise she's not going to have the signaling that she needs for milk production. So we want to breastfeed plus pump early, pump often, pump after feedings. And if the baby goes to breast, pump in place of feeding if the baby's not effectively feeding. And we want to have that goal of 8 or more in 24. And we want to really be assessing for risk factors. And we want to be ensuring that we're coming to volume by day 7. To maximize the baby's ability to get colostrum, we want to initiate with the initiate technology because we know that this is a research-proven intervention that allows for the milk to be removed more effectively, and also, importantly, for the parent to come to volume in a quicker time frame post-birth. So again, it's all about getting milk supply established because if we don't have milk, we can't have breastfeeding. The initiate technology has been used in all different gestational ages, preterm, late preterm, and term birth, and again, shows effectiveness. So it should be used anytime there are risk factors or we have separation or a baby not feeding effectively. We also want to have the parents pump both breasts at the same time, even if the baby fed from one side, still have them express both milks at the same time. Because of the research from Dr. Danielle Prime, right up here in the upper right-hand corner, University of Western Australia, 2007, we know that simultaneously expression means you have better release of oxytocin, you get more milk volume, and you have a richer, creamier, higher fat content for the milk. So if a parent had to pay out of pocket for a pump, and if they did that for an entire year, that would still be less expensive than the cost of infant formula. So most of the time, the parent's not going to need that hospital grade pump for a full year because unless they're choosing to be pump dependent and feed only express milk. So when we think about costs and that's majorly cited as a reason that parents can't do this is because they can't afford it. If they were feeding formula, they would be actually spending more money. And even those parents enrolled in WIC, we know, have to spend about $50 additional each month to purchase infant formula, even with the free formula they get from the WIC program. The other thing that Dr. Prime has done is she has redesigned the breast shield. So hopefully you have all seen the new Flick shield. And the research on this found that not only did the lactating parent have an improved comfort when pumping with the shield, but they also more effectively removed milk from the breast, an extra 11%, which means, again, you have higher calorie, creamier milk for the baby, and it means you're going to drive milk supply to be higher. Discharge guidance. Keeping that baby skin to skin for as many hours of the day as possible. I tell my new parents who are going home with their child to plan to be topless for the first 2 weeks. Having that baby skin to skin allows the parent to start feeding when the baby is quiet and alert. This means that the baby needs to be in the same room with a lactating parent. And we know that families, especially in the US, spend a lot of time and energy during pregnancy preparing the nursery. They build a separate room, they decorate it, they get a crib, they get a glider, they get all kinds of beautiful things for this new nursery that they've invested lots of time and lots of money in. But really, to facilitate breastfeeding, that baby should be in the same room with a lactating parent. So to end our day with, so we have time with questions, I just want to share one case exemplar of proactive management. So this young lady was a personal friend of mine who allows me to share their journey. She asked me to do a prenatal risk assessment for her. I did so, and her two major risks that came out was that she was a first-time mother and she was over age 30. So not so bad in terms of risks. She did plan to give birth at a baby-friendly hospital facility with nurse midwives. Now, when she presented to the birth hospital, she presented in early labor, and it was actually during a holiday weekend. And so when she presented to the birth hospital, and there are midwives at this hospital 24 hours a day, 7 days a week, they said to her, well, you know, you could go back home and you could just keep on laboring at home because you're in early labor, but it is a holiday weekend, so you could just stay and we could just give you a little Pitocin to help things along. And so I'm sure they were just trying to be helpful, but she did end up taking the Pitocin, which then meant she had some really uncomfortable contractions, which then meant she had an epidural. So she was lucky that she did end up having a pretty short labor and a good birth. And at the baby-friendly hospital, her baby was breastfeeding vigorously from birth. I went to see this family at 12 hours because, again, this is someone I know personally. Everything looked great. I went to see them 24 hours later when the baby was 36 hours of age. Mom felt good. Baby was breastfeeding. I could see visible colostrum after the baby suckled. But I said, you know, I'm just going to leave the symphony pump here with you because I have it. I brought it for you. I want you to have it just in case. So the next morning, they do the routine bilirubin prior to discharge, and it's 13.2. There. Sorry about that. So they do the bilirubin and it's 13.2. They tell her to go home and that the baby has to stay for phototherapy. The mother said, I'm not leaving without my baby, so you better find some place for me to stay. They did recommend she gave formula to the infant. She did refuse. She called me. She was in tears. She said, I don't understand. I took all of their classes. I paid money to learn about breastfeeding. Why do they want to give my baby formula? And she was hysterical. So I told the mother to request pasteurized donor human milk because I knew this particular hospital had it. But she was refused because she said that her baby didn't meet their criteria for pasteurized donor human milk. So the baby ended up getting moved from the well baby floor to the NICU. She was forced to give the baby formula overnight, Thursday to Friday. And then she was discharged on a Friday afternoon with instructions to take the baby to the Child Care Network site for a bilirubin and weight check that Saturday. At home, she had been doing lots of skin to skin. She was breastfeeding and pumping several times a day. I did a home visit when the baby was 96 hours of age and the baby transferred the 96 mLs. When I went to see her later, at the second home visit, sorry about this, the baby was 7 days of age and the baby had gained 98 grams, milk transfer of 22 in just 3 minutes. What we later found out was the reason for this bilirubin being high at day of discharge was that the baby was actually an ABO incompatibility. However, they had never given her that information in the birth hospital. This baby really probably never needed to have any formula, but we did need to support her with her milk supply and her breastfeeding journey. Thank you, and I believe we have about 5 minutes for questions.
Thank you, Diane. Yeah, we've got about 5 minutes. We did have some questions come in, so we will get to those. The first question that came in early on in the presentation is, how can we get a copy of the new 10 steps infographic?
You can contact me via email.
Okay, and I will provide Diane's email after the call to everyone, so you'll have that. And the next question was, or actually a statement, the video was really hard to hear and it was kind of choppy. So is there a clip that you have or a link to that clip that I can email everyone so they could listen to it at a later time,
Yeah.
Diane?
Sure, I'm sorry about that. I know that is one of the problems with online learning. It doesn't always work well on all platforms. It works better on some platforms than others. But that link to the video is available if you go to chop.edu/breastfeeding. Both the power pumping and skin to skin DVDs and the information about both of those videos are on our website as well.
Okay, great. Thank you. And then the last question we'll have time for is, how should babies with low blood sugar be treated?
It's a great question. So this is where I think antenatal expression may be appropriate, because if you look at the largest study ever done about antenatal expression, it was for women who had diabetes. And we know people who have diabetes are at higher risk for having babies who are LGA and babies who are going to be at risk for hypoglycemia. So in that particular population, antenatal expression of colostrum may be appropriate. But again, I still think we need some more research. I also think when we're thinking about babies with hypoglycemia, we want to think about what we are doing to protect breastfeeding, right? Are we protecting breastfeeding? So for example, in the last case I shared, at that particular institution, they had a policy in place where they used pasteurized donor human milk for term infants with hypoglycemia, but they didn't use it for babies who had jaundice. So that was like a really difficult thing for that parent. So I think it would be appropriate to supplement with pasteurized donor human milk when we have hypoglycemia. But if we're going to do so, again, we still need to get the parent pumping, because you can't say the S word without saying the P word, right? Because if we don't stimulate the breast effectively, even if we keep that baby exclusive with pasteurized donor human milk, we're not going to have effective stimulation to the breast, and we could further delay lactogenesis too. So my preference for those children would be to support them with a little bit of pasteurized donor human milk as warranted, but in small amounts, no more than about 5 mLs. Get the lactating parent expressing so that we can bring them to volume, and preferably avoid the use of formula in those cases.
Okay, thanks, Diane. It looks like we're at the top of the hour. We did have some questions about getting a reference list, and I know that there's references to all of the articles that you talked about. I can send those out to everyone after the call a little bit later today. But thank you again for presenting this great information. It's always a pleasure to listen to you present your information. You have such great information for everyone. Just a quick reminder to everyone, registration is available for our April 21st and June 3rd webinars, and registration will be available shortly for our May 13th and 19th webinars soon. And I encourage everyone to visit Medela.us, our refreshed website with links to the initiation of breast milk, information on COVID and breast milk feeding support, and also our enteral feeding solutions that we offer. Enjoy the rest of your day. Have a great afternoon, and thank you everyone for joining us. Thank you, Diane.
Thank you. Bye-bye.